Hello, this is Dr. Anchal, and today we're talking Guillain-Barre syndrome. So let's start. It is an acute autoimmune bilateral polyradicular neuropathy causing a rapidly evolving areflexic ascending paralysis in those affected. It is mainly of four types, that is AIDP, AMAN, AMSAN, and Miller-Fisher syndrome. AIDP, also known as acute inflammatory demyelinating polyradicular neuropathy, it is also a most common type, presents with anti-GM1 antibody. AMAN, that is acute motor axonal neuropathy, presents with anti-GD1A antibodies. AMSAN has a relatively poorer prognosis, does not show any antibodies. And finally, the most important, Miller-Fisher syndrome, which presents with ophthalmoplegia, areflexia, ataxia, and demyelination, and they present with anti-GQ1B antibodies. The patients presents with a very short history of tingling and dysesthesia of lower limbs. They typically describe it as rubbery leg. It is rapidly progressive, bilateral, areflexic ascending flaccid paralysis. This disease mostly involves the large fibers, that is the type A alpha fibers, in distal to proximal fashion. Talking about triggers, about 60 to 70% of uh, of cases are preceded by infections such as gastroenteritis or UTI. Certain triggering pathogens include Campylobacter jejuni, cytomegalovirus, Epstein-Barr virus, Mycoplasma, Hep A, Hep B viruses, and HIV viruses, etc. It is suggested that these triggering pathogens show molecular mimicry, thus cross-reacting against myelin sheet of our neurons. GBS is mostly a clinical diagnosis where we may also use the Ashbury and Kornblath criteria for diagnosing the same. Electrodiagnosis is found to be more sensitive type in evaluating the GBS patterns. Finally, the management include PLEX and IV immunoglobulins should be given at the earliest and at least within the 4 weeks from the onset of the symptoms. Thank you.